We're going to go ahead and get started our brief wrap-up session. We want to thank all of you for participating the last couple of days. I think it's been a good event, and it's really as helpful for us as we hope it is for you in learning about what's going on. So, and there's a lot of good going on, so thank you very much. I think, you know, we know we have a lot of work ahead of us. We have done a lot of work. You all are obviously doing great work. We know that with the extension negotiation and with some changes and improvements we'll make to the program together, we have our work cut out for us. Our DOS and I were just talking, you know, between, you know, data exchange and evaluation and the work going on with the clinical champions, aligning with the managed care world that we're in now. None of that is necessarily easy, but we know we need to start taking further steps. So we're going to do it together. You know, I was really encouraged by the group we had that was the Clinical Champions panel this morning. Hopefully you can see that through that process we are wanting to identify strong practices, high impact projects that we can use to help strengthen overall this program. And I think our representative from CMS who is here, when he was leaving, I think him being here, he can see the impact that this program is having on Texas. And I think it's important for him to see that firsthand, and that helps us as we ask CMS to allow us to continue all of this. We do not have major additional information. We did want to be available to answer any other questions that you might have about the extension, about the future of DSRIP, about the, I think somebody said this morning, the energy yesterday was good, the energy this morning, a little medium with, as we get into those details of changes we may need to work to make, we know that's not as inspiring, but we'll keep working with you on that. And I learned some things today that, you know, we value your input a lot. So I learned some things this afternoon, and I think our staff did in different sessions that we're going to keep using as we keep tweaking the proposals that we're going to bring forward to you at the end of September about the district protocols. So with that, do we have any more questions? And yes.
I just have really a question and a suggestion. A clarification for me on the evaluation process. Is that going to become a formalized process with expectations for us to be reporting those evaluations back to you all?
That's a good question, and I was in the evaluation session this afternoon, and what we're thinking right now is that as we streamline metrics for Category 1 and 2 projects for the extension, one of the metrics will be related to sustainability planning, and some of that is giving us whatever information you have about project level evaluation. So I do think it's something that we recognize we wish we would have done more upfront. And now we have probably another opportunity as we look to how do we sustain these long term to really be asking all providers to, in the context of their project, to be looking at that.
So with that in mind, because I think the evaluation process will be intriguing and give us a lot of a real viewpoint of some of the things that we've done and be able to give us a way to look at how it's affecting the whole state. But I know from the process piece of this, it would be very helpful for us to have some lead time to prepare for that so that the data that we're pulling, we've been able to identify that and have a start time in which we're going to be able to capture it. Because going back and asking for data retrospectively is sending, on any issue, not just the district project, but other reporting agencies that are wanting it, it's sending our IT departments up the wall. And they keep saying, why didn't you ask us for this in the beginning? And they're so involved with the ICD-10 process right now that, you know, I just want to make sure that we give them plenty of time to get over that and for that to happen before we start looking for more data from them.
And you know, what I would recommend if I were you, and we are still thinking that metric would be a project level, so it would be tailored to your project. What I would recommend you start doing, and the group that, the evaluation session today I thought was really strong about some ways to begin to, some tools to begin to structure looking at a project level evaluation, is that you think about really for yourself, if I'm gonna be wanting to better evaluate the results of this in the next 3, 4, 5 years, what data would you wanna have? And then you can start building that in with your IT department. But I don't think there's any intent of a lot of retroactive, we're not trying to create retroactive work, but really trying to encourage people going forward to be looking at this data to help inform how we keep these projects going in the future.
Okay, go ahead.
The state, or the regional part will be state level data. So the data that you would be working on for project level evaluation would still be at the project level, yes.
Yeah, and so I was just going to say that many projects are already doing it now. So there's no reason not to already be doing it.
We'll be working out the details, but I think there'll be substantial flexibility, but we will be asking you to do it, but we know that there'll be a lot of different ways that people are doing it.
Hi, I have a question. I'm from RHP5, and I have a question related to the bonus pool. So our RHP, or our anchor is exempt from the Learning Collaborative and Raise the Floor improvement initiatives. And I know that's a really good opportunity for regions to work together toward a certain goal. And so when I thought about the bonus pool and how that is going to be RHP wide, is there some sort of idea of who would be leading the initiative, and if the answer lies in the anchor or the anchor entity, is there a way to remove the exception process so that the anchor can play a more leadership role, or is there an opportunity for a provider to lead that role too?
That is a very good question, and we are still thinking about those details. So appreciate the thought and the input. We have been asked, okay, if you're going to have these regional bonus pools, that's going to take more work at the regional level, even in the regions that have learning collaboratives, to kind of be getting everybody together to be working to improve on certain measures. So we'll need to think about that for the regions that are exempt currently. I would think that that those efforts could be coordinated well by an anchor, but if the anchor didn't feel like they had the administrative capacity to do it, they could also be coordinated by providers in the region. Dr. Levine, over here, and then we'll.
We have a project that, since we started it, has become Medicaid reimbursable in other states. And so when we look at the sustainability, I don't know where we're at in Texas in terms of how we would bring how something is Medicaid now reimbursable in another state to here, to either have it as a project or to look at the sustainability. Do you know how we're going to look at those issues?
Sure, and the Medicaid benefits process is a fascinating process. The other part of the Medicaid program that I work with, the Office of Policy, is responsible for moving through changes in Medicaid benefits. And so we do have a formal process where you can go to our website and say this is whether it's a drug or a device or a service like peer support specialists or whatever it is that somebody thinks we should be considering adding to the Medicaid program. Folks, there is a structured way that people can ask for that. It's a pretty rigorous clinical process in terms of evidence-based. And of course, initial fiscal impact to the state is something that we always have to look at. So if adding a benefit has a fiscal impact to Texas, then we've got to get approval from our state leadership to add new Medicaid benefits that would have an upfront cost. Even if they would save money in the long run, if there's an initial budgetary outlay to do that, we've got to get approval. But part of what we're doing here is that we want to get, I think we've heard here, community health workers, peer support specialists, and we also have some flexibility in managed care that the plans, and they can speak to this too, but the plans have more flexibility than fee-for-service to do some things that are not a traditional Medicaid benefit if they're finding it's cost effective and health effective for their members. So one of the things that I know Kay, I'm sure Kay spoke to this afternoon, is that we're looking our plans have medical costs and they have administrative costs, and we cap how much they can spend on administrative costs. So one of our initiatives right now is to see what else can we add to the medical cost side, things like care coordination, peer supports, those kind of things, to encourage the plans to use those if they find they're effective, rather than kind of making them reluctant to use them because they know they're hitting up against their admin cap. So we're looking carefully at that, but certainly I don't know what your specific service is. We can talk more about it. Well, and just as a reminder, every state has its own Medicaid state plan, so it could be that 40 other states cover it and we don't yet, and Texas would still need to decide that Texas wanted to cover it for it to become a Texas Medicaid benefit. But we can continue to work with you on that.
And we do have a coordinated process in DISRIP with the policy shop to look at evidence from district projects when those benefits are reviewed. So, we can put a link on the waiver website to that process because it's a different part of HHSC's website where that is, but we can put a link. We have sent it out to the anchors already. And it's a pretty rigorous process, but we would encourage you to go ahead and do that. And one of the ways for sustainability is to incorporate it into Medicaid. So that is, a sustainability strategy that's worth pursuing. And if we can show that it's cost effective and that district pilot projects have shown evidence of cost effectiveness, we think that will help.
I was wondering if you could speak to, if we are to assume that we got renewed, what the timeline would be looking at with that. For the example, if you have programs that needed to carry forward metrics into like a phantom DY6, how that would transition into the renewal.
So we got this question earlier today, and some details are going to need to be worked out. We currently have carry forward authority in the existing waiver from DY5 into DY6. So that's not going to go away. Now, when you get into what does the new world look like in DY6, are there new rules? Does CMS allow carry forward? We're going to need to work through that with them. And some of that timing is uncertain because of the negotiations timeframes. But what I'll say is that we will advocate strongly if we need to for a transition period, if it's taking us a while to negotiate with CMS. And I think Tim Hill heard, you don't turn this ship quickly. So if we're going to make changes to this program, as large as it is and as many providers as we have, we just need lead time to do that administratively. And I think they understand that.
I do have a question, but I want to take an opportunity to thank you both and your team for your leadership and advocacy and guidance in all of this. So, and an excellent conference, by the way. My question is an evaluation question. So if we're to sort of undertake kind of a new evaluation era for these projects, is there an intent by the agency, specifically relative to the waiver, to develop its own logic model that has a little bit more substance and guidance, and even work with the regional anchors to sort of develop their logic models? My own comfort zone historically is working with families of logic models that kind of flow together rather than developing these independent kind of projects, and they're all sort of hitched to just the triple aim, basically. So I'm just sort of wondering what the plan is relative to that.
So there isn't a plan right now, but I think it's a good point. Should HHSC work to put something out that people can use as a framework? So we will take a look at that. I'm going to admit, I don't know that much about logic models, but we were talking with our formal waiver evaluators, even at HHSC a couple of weeks ago, and we do want to look, I mean, we've got that formal waiver evaluation that's out there that's different than this, but they should be connected. We should be working together because we know that there's a lot of good information on district projects that we want to use, you know, to inform the future of the program, to show our results. So thank you for that comment, and we'll add that to our list of things to work with you all on.
Hi, Lisa, thanks. It's always interesting doing population health management in the population that can seek care anytime, any place, or go to an emergency room at no cost if they so choose. And a couple questions. One is, with the data we saw earlier about how Texas Medicaid ranks nationally among Medicaid programs, I'm wondering if there are any signals in there about how other states handle the freedom of choice, primary care provider, and how frequently you can switch, those sort of things that might be a signal to look at characteristics that identify higher performing state level programs. And I just don't know if that's a Texas thing or if that's a common characteristic across Medicaid programs nationally. And the other question would be whether there is any, whether anything's resonating within the Medicaid organization about potential changes to that process that might be necessary or advantageous to drive quality population health down the line.
And when you say changes to that process, could you just clarify?
Well, I'm thinking, you know, compare it to Medicare managed care, where you have a PCP, you have a limited time period in which you can change providers. You know, care is not necessarily reimbursable if you don't get your referral from your PCP or you're seeing your PCP.
So, you know, we would have to do a little bit more digging on, you know, and I'm sure ICHIP has it, but if you look at some of those HEDIS measures, how other states are performing, and in the strong performing states, what are the differences? And certainly our managed care folks who have been here but may not be here now also may know more about that. So we'll double back with them. You know, Medicaid has pretty liberal, you know, we have a challenging time because of federal requirements locking people into a plan, and even into a PCP. There, you know, that there's a good amount of flexibility in Medicaid if somebody wants to change for cause. So I don't know how much more we could do there, but we could definitely look into that.
I'd just really like to second Dr. Romano's comments, because without true impanelization, you could never make a difference. And so, you know, I think that different Medicaid plans than some of the states I've been in, they did give people the ability to change once in 3 months for cause. And, you know, so I mean, I think that I don't know what the current rules are in the US plan, but I do think that would be extremely helpful. Because especially for a 2-year-old, you know, trying to get that immunizations in, trying to get that beginning critical first 2 years of care really thought through and organized, it makes a huge difference. Thanks.
Thank you. And we know we have challenges in data in general in our Medicaid population just because people are moving and moving in and out of Medicaid. So we have a lot of inherent data challenges, even if folks stayed with the same PCP or plan for as long as they're with us.
Is this on now? Okay. Regarding sustainability of the district projects, we're a community center that provides mental health services. Only about 50% of our clients are Medicaid. So you can see that if district dollars go away, even if MCOs begin to pay for more services, our projects aren't going to be sustainable. Is there any thought to maybe DISH's HHSC beginning to pay for some of the services that we're providing through the district projects, such as primary care integrating with behavioral health?
So this is a giant challenge that we all share, that we know that if DSRIP goes away, DSRIP is currently serving a lot of folks that don't have another source of payment, or is enabling them to get better services or more services. We do have some state programs, like the primary care program or other programs for people that don't qualify for Medicaid. Those programs are limited in their funding. So, I mean, on the Medicaid side, we can look at what we can do, and even in those programs, we can look at what we can do. But the reality is, this is a lot of money that's been infused into the system to help provide care for those folks. So, we'll be making that point strongly to CMS. I mean, it's a delicate balance because they have their preferences, which are expansion over these kind of supplemental programs. But Texas also is where Texas is, and a lot of good work is going on. So we're gonna try to make the case, you know, certainly in the short term, to allow us to continue the good work that's going on, even if this isn't something that they see as a 20-year plan. You know, additional funding comes from the legislature, comes from our budget process, or other funding sources, federal or whatever. So, you know, those are things that do take a while. If folks advocate for additional funding, sometimes we get additional money for those types of programs. We've definitely seen boosts in mental health funding in the last 2 legislative sessions. So sometimes we see increases, but we're just not sure. Any other questions? Wonderful. Well, then thank you so much. We are going to free you for the weekend. And we have a short video. One more short video. It is not of us. We have not made any videos.
It's healthy kids.
As you, yes. One more short video.
The Healthy Kids program, really what we were trying to do was just expand pediatric services in the Permian Basin. For a long time, you know, we've had some great pediatricians in the area. Always, you know, have done a wonderful job taking care of our children, but we just wanted to take that next step. And that next step included, you know, getting more pediatricians in here for just general pediatrics. We wanted to form a partnership with a children's hospital to provide some more specialty care in the area, so our patients don't travel so far. And then the third prong of it really was the health literacy part, which is where health teacher and our partnership with UCISD.
So the main goal was to establish more like a medical home healthy clinic. So not just for sick visits, but also for preventive care for the children. And so that's what we see from newborn follow-up all the way through 18. And so it's not just for, and you know, obviously if they're sick, it's also a nice place for them to come because we know them, they know to come here for their checkups. And so if there's something wrong, it's also a good place to come because we can compare their exams. And so that's the main goal. It's like a total care, not just sick visits, but also preventive medicine. I had a couple of new moms tell me, oh my goodness, this is just 2 minutes away from where I live. And I actually hear that a lot. And so it makes me happy. I'm like, okay, good. There's, you know, it's a lot nearer for them. They can just, you know, drive by, finish the exam, drop off their kids, and then go to work. So it's been really good.
Odessa, Texas, West Texas, is #1 in so many health problems. And some of that blame has to be laid on the shoulders of the educators in our town. You know, there's community, there's family, there's all kinds of different things we can blame it on, but we've got to take some responsibility in our field, physical education and health, and try to correct these. And so we've been trying to find ways. The health teacher from Medical Center has been huge in that. We've got to find ways to try to get our kids to understand that the decisions they make at this age, a young age, before they become adults, are going to affect them for the rest of their lives. Ideally, every student in the district getting some Go Noodle activity during the classroom every day, and every student in the district getting weekly lessons from health teacher. Every day being physical, every week getting a health lesson. And I think we can change the decision-making process of our kids. That's our goal. At this age, a young age, before they become adults, are going to affect them for the rest of their lives. Ideally, every student in the district getting some Go Noodle activity during the classroom every day, and every student in the district